I'd like to introduce you to our next speaker. Gabrielle Chan is a research junior specialist at UCSF, and we were privileged to work with her last year. Some of you may have met Gabrielle either in person or in a Zoom meeting as she interviewed you for her research. And now we are happy to hear from her and see what lessons we can learn from her work here in the Philippines. So, Gabrielle, over to you.
All right, so I'll just jump right into it, and I ask that you guys save your questions for the very end, and I'll be happy to answer them. Okay, so the study was titled Reaching the Third 95 Target in the Philippines, a qualitative study of provider perspectives on the barriers and facilitators to viral load suppression. So to give a brief background on the study, I wanted to highlight the statistic from this 2022 care cascade that viral load suppression among PL/HIV on ART is only at 27%. And I'm sure you're all aware of the magnitude of the epidemic in the Philippines, being physicians there yourselves. So I won't get too deep into the epidemiology. And we're here today under the CMMQI Learning Network, which is currently focused on viral load suppression, or VLS, in relation to drug resistance and ART management. And from previous literature, and likely from your experiences as well, we know that HIV as a disease and VLS as an outcome are multifactorial. So to contribute to the root cause analysis of the QI aspect of this network, and to explore the underlying factors of VLS in the Philippines, my research question was then, what are provider perspectives on the barriers and facilitators to achieving viral load suppression for HIV treatment experience and complex patients in the Philippines? And our objective was to find prevalent themes and trends of these perceptions. So since this was a qualitative study, qual methods were used. To select the sample, we purposefully sampled this network that we're in using the following categories: facility type, region, and physician specialty. And after obtaining informed consent from the participants, I then conducted in-depth, semi-structured interviews with the goal of exploring the factors of patient, provider, and system, which I'll get into later. And the participant responses were then coded and thematically analyzed. All right, so here's an overview of the sample characteristics. 13 physicians participated in total, the majority of whom were from tertiary level facilities and from Luzon, specifically the NCR and Region 3. And then others were from Cebu or Region 7. And there was also a good mix of experience, years of experience caring for PL/HIV among the physicians. So I will talk about these results more in depth later, but here's a summary of the themes of the barriers that we identified. And although I siloed these themes into the factors of system, provider, and client for the purpose of addressing my specific aims, it's important as I go through these to keep in mind that many of these actually intersect in the real world because of the nature of HIV and treating it. And also we'll see that one factor like system may shape the barriers and facilitators of other factors. And here they are for the themes of facilitators. Clearly fewer than barriers. All right, so the first result is centered around barriers and facilitators that pertain to resources. So participants expressed the most frustration with this during interviews and just discussed it quite a bit. So specifically for ART, they identified frequent stockouts as an impediment that contributed to treatment interruptions, which led to practices like rationing and reduced pill dispensing. And many also talked about regimen shifting, often unnecessarily because a regimen would be working well for their patient. There were also a few options to shift them to. And in cases of like a client having side effects or a pre-existing comorbidity, or if there were indications of virologic failure, then physician choice was constrained by the lack of both supply and choice. And on the client side, this frequent regimen shifting or unideal ART prescriptions could contribute to like poor adherence practices. Now, as a workaround to this, physicians relied on informal regional networks, especially when they needed supplies of ART. So while some did not experience issues with the supply, almost all pretty much did acknowledge the existence and positive role of these networks, where physicians could reach out to other physicians or other facilities and ask to borrow supplies from them, which would help them to avoid treatment interruptions. Okay. And then lack of access to testing was another major barrier. Some participants had to rely on government-donated viral load tests, which were at times not enough. There is a national insurance package for HIV/AIDS clients to have lab tests covered, but it's likely that bureaucracy at the administrative level may have caused inadequate medical coverage, especially for the unique needs of treatment-experienced and complex patients. So drug resistance testing is also a major barrier, as only, I think somebody has mentioned this in prior meetings, that only 2 institutions in the country are able to do it. And physicians have attempted to work around these issues by blind shifting, which is a lay term for just shifting without the viral load tests and without the drug resistance testing, and utilizing clinical symptoms as a proxy. However, both tests are very critical standards of care, because viral load can begin to elevate before a client becomes symptomatic. And test results, at least those that show improvement, are a great motivator for clients to continue taking their medication. And obviously, without these tests and these test results, it's hard to accurately know how a client is responding to a treatment. So we can see that lack of testing resources in ART are both barriers that require policy-level interventions from the Department of Health, who participants cited as responsible for procuring free ART and producing treatment guidelines. Since currently the solutions providers have or are currently implementing are contributing to some technical inefficiencies in the system, and do leave some room for error. However, QI is helping us to reduce these gaps in provider care through interventions like the learning session that we're going to have today, and routinizing processes to maximize quality and efficiency within system constraints. All right, sorry, 1 second. Okay, and certain physicians also cited a need for personnel support to reduce their task loads. So for example, some physicians from primary level clinics held other responsibilities in addition to seeing clients, such as seeking funding for their clinics. And then other participants in a tertiary hospital mentioned needing coworkers to cover some of their tasks. But more importantly, a few physicians discussed their limitations in psychosocially counseling a client beyond the typical adherence counseling, which highlights the lack of interprofessional roles to support a multifaceted care approach. So other participants did have options that they could recommend their clients to, which were in or nearby a facility, like staff counselors and peer counselors. And in terms of QI, I think this is one area where there can be a difference made for improving clients' adherence. So in addition to expanding evidence-based counseling that physicians practice, especially with adherence counseling, I think the implementation of these roles and similar approaches to interprofessional care can alleviate providers' loads while helping clients to build a support system. Also, routinizing a referral system for the unique needs of certain populations, such as people who use drugs or PWUD, may possibly help improve their health outcomes as well. All right. And as we all know, both external and internal stigma remain rampant in the country, which poses multiple barriers for clients to stay on timely treatment. And in one specific case, it inhibited a client from divulging their true status to their physician. So participants recommended that greater awareness among non-HIV physicians and other healthcare roles may reduce a significant proportion of the stigma that clients face. And everyone pretty much agreed on the vital role of family and community support on adherence, mental health, and clinical symptoms. So given the magnitude of stigma in HIV, our results in previous literature also support the implementation of both policy changes and QI efforts, which could manifest into things like national to community efforts, not only for HIV, but for the advocacy of subgroups with HIV, and incorporating targeted stigma reduction training into the general medical education curriculum. I also wanted to mention that community efforts have really paved the way for HIV awareness in the Philippines, and I think those should definitely be continued and scaled up. Okay, I don't know how long I've been talking, so I'm not sure how much time I have to go over these other barriers and facilitators, but I think they're also important to consider, especially with the COVID-19 pandemic and how that caused a lot of treatment interruptions for many people all over the world, essentially. And that socio-behavioral client characteristics, as well as transportation and competing priorities, also contributed to the level of health seeking that clients had, and it played a large role in the success of a regimen. Other facilitators are financial support for clients, and like I mentioned earlier, monitoring and evaluation system. And there were definitely limitations to the study, such as the lack of different perspectives of different healthcare roles, and also we weren't able to interview any clients or patients for this study. The small sample size and certain things about the methodology that if you have questions about, I could definitely answer. But what I wanted to highlight from the study was the discoveries of what has worked despite the constraints of the system. So over the past few years, VLS rates have grown because of things like informal regional networks, which I think showcases the adaptability and creativity of physicians, local community efforts, the introduction of interprofessional roles, and the implementation of QI initiatives within the country. Okay. Yeah, and I also wanted to thank every single person that's listed on this slide, who are all very instrumental in this study and allowed me to to work with them and do these interviews in the Philippines. So yeah, thank you for your time. And if you have any questions, I'm happy to answer them.
Thank you so much, Gabrielle. It's great to see the product of your hard work. It was such a challenge for Gabrielle really to move around, especially during the time that she was here. We were still struggling with the remnants of the pandemic, but I'd like to thank each and every one of the participants of her qualitative study for giving her the time and making her stay here very welcome. We enjoyed having you, Gabrielle, and I hope you had fun as well. Thank you for documenting the barriers and facilitators of viral load suppression. Some of these we really have experience on a personal level, and we are hoping to invest in the facilitators that you mentioned so that we can achieve better outcomes in the future. Thank you so much.
Thank you so much for having me.